Hola, buenas tardes, ¿cómo les va? Bueno, esta vez les voy a dejar con un subtitulado de una charla entre Vincent y el profesor Marvyn Singer, que como se acuerdan, ese fue el primer autor de, del tercer consenso acerca de las definiciones de sepsis y shock séptico en el 2016. Más que nada, esta charla la va a centrar en lo que es el uso temprano de antibióticos en los pacientes que no están con shock séptico y su postura acerca de eso. Esto también de cara con, con la salida de las nuevas guías de la campaña de sobreviviendo a la sepsis, del manejo de la sepsis y el shock séptico, donde declara algo más o menos parecido, donde dice que, bueno, que la mortalidad eh, la reducción de la mortalidad, mejor dicho, asociada al uso temprano de antibióticos, está asociada más que nada a los pacientes que tienen shock séptico. No tanto sí para los pacientes que no están en shock. Bueno, este, les dejo el link en la descripción del video para bajar estas guías. Les dejo en la página, también dejo el link hacia la página de uso online. Y bueno, los dejo con el video.
Hello, hello. We are here today with our good friend, Professor Marvyn Singer from the University College of London. Hello, Marvyn. Of course, Marvyn is well known in the field of intensive care and other fields. And we'll speak primarily about sepsis, I guess. Marvyn, I would like to ask a provocative question. If we think that antibiotics work in severe infections, we should give them really as soon as possible, right?
Well, I suppose, thank you, John. That's the theory, but the reality in terms of the published literature doesn't actually reflect that. So, there are so many confounders. When the patient comes into hospital, they may have been ill for hours, days, or even weeks with an infection. So just to believe that the clock starts after they've entered the doors of the hospital or the doctor makes the diagnosis of possible infection.
But they may get to the hospital when they are worse, when they become septic. So it may still be a sepsis of relatively recent onset, right?
Yeah. So again, to my way of thinking, and again, the way the literature reads is if you have a very sick patient, they're in septic shock, you need to react quickly, just like somebody bleeding to death. If they've got hemorrhagic shock, you're not going to wait, an hour for a full cross match. You're going to react promptly. And I think the same analogy can be given to a septic patient. Clearly, if they're very ill or they're deteriorating very rapidly, you need to react. But the literature shows that for the vast majority of septic patients who are unwell but not moribund, very critically ill, you've got a bit more time to try and work out, have they really got an infection?
Would you be willing to do a prospective RCT randomized control trial on these patients who are septic but not in septic shock?
It would be a lovely trial to do. I don't think this is going to be the problem. We were discussing this actually a few weeks ago. Would there be the equipoise or the fear? Because I think, unfortunately, there's been a lot of, for want of a better word, propaganda. Early antibiotics save lives, etc. So it becomes very hard to.
Yeah, people believe in it.
Medical legal, dogma, all of these other issues. But clearly that's what needs to be done. I think one of the things that's helping, if I can come on to that, is that there are now position statements from the American Infectious Disease Society of America, the American College of Emergency Physicians, all have recently come out with statements saying you don't need to rush to give antibiotics in the first hour unless the patient's very ill. So
Yeah, well, we'll speak in just a second of the first hour concept, but I wanted to add, those who advocate the very early administration of antibiotics say that you can still stop it after, well, after 1 hour or 2 or 3, if you realize that this was not necessary, and then it would not harm to give 1 dose of antibiotics. What do you think?
well, I think the reality, again, looking at human factors, once they've started, it's actually doctors find it difficult to stop.
Yeah.
And I think, you know, there's this mentality, oh, well, let's finish off a course.
Yeah, yeah, absolutely.
My worry is and I'm sure you've seen it, Jean-Louis, and everyone listening to this will have seen it, that often a patient may be pigeonholed as, oh, they're septic, and then the clinician's brain switches off and they don't think, well, could this be another non-infectious pathology that could...
Absolutely. And of course, we are concerned about the emergence of resistant organisms, right? We don't want to overuse the antibiotics, right?
Yeah, no, 100%. You know, we know from the ears epidemiological studies that it's, you know, year on year, it's sweeping up from South and East Europe, and it's moving ever northwards, and you know,
sure. Now,
big problems.
There is this 1 hour concept. Do you like this 1 hour time limit in a way?
No, because I think we need to look more at the patient and be patient specific. So it needs to be much more predicated on severity and trajectory. So the reaction time of the clinician needs to be commensurate with the patient in front of him or her.
But then people could say, Mervyn, we need to measure what we do. And if we want to compare our strategies and the quality of care in the various institutions. So how would you do that?
Well, I'll go back 15 years. In the United States, they had a quality program, and obviously there was a sort of financial penalties or incentivization, depending on which way you look at, to give antibiotics within 4 hours of presumption of a chest infection or pneumonia.
Yeah.
That got abandoned because they realized all it was doing was encouraging doctors to overprescribe antibiotics, and they found there was no outcome benefit.
Yeah, I'm afraid we agree. What do you think about these bundles then? Not only the antibiotics, but, you know, fluid, vasopressors, lactate, etc. in 1 hour.
Again, I think you and I have sort of pronounced our views on this more than once at meetings. It's, again, you're trying to pigeonhole, force patients to get an identical treatment regimen, when at the end of the day patients are different, and we need to adapt our treatment to the patient. So giving 30 mils per kilo, it comes out of nowhere.
Doesn't make sense.
A patient may need 10 mils, they may need 40 mils, but the only way you know is to give a challenge, look at the response, give another challenge, etc. But you're not mandated to give a huge amount of fluid. 80 kilo person, 30 mils per kilo is 2.4 liters in an hour.
But the timing for some things is relatively long, because you are supposed to start fluid administration within 1 hour. But I would argue that you would have 5 minutes to start fluid administration. Likewise, to measure lactate, you don't need to, you know, have 1 hour to measure lactate levels or to correct hypotension, right?
I think, again, there's this sort of fixation with looking at the clock. And again, there should be a sort of automatic brainstem mode. Right, you've got a sick patient, they need ABC, they need a diagnosis, they need stabilization. And, you know, all of the, you know, when you decide to do an X-ray or a CT scan or a lactate measurement or use an ease, that all is a bundle that all comes together. So nobody's disagreeing with the fact that all of these things need to be done as part of good practice, but to mandate they need 30 mils per kilo, why?
Yeah.
There's
Yeah,
no
sure.
space for it.
What about the source control? Do you think there should be some time limit, or what would be your advice on this?
Again, it's when you look at the literature, you know, there's no absolute, oh, you've got to get in there within an hour or two. You know, I've been looking at the literature recently on this, and there's not very, very strong data. I think the concept is, you know, clearly if you've got pus or a perforation or whatever, antibiotics aren't going to be particularly effective. You've got to treat the problem.
Yeah.
But clearly you need to get the patient fit enough to be in a state to have the major surgical operation.
Yeah.
So again, it's a balancing act of that patient in front of you. You need to try and get hemodynamic stabilization, electrolytes, fluid, etc., then get their operation done. So you shouldn't delay the operation, but on the other hand, you shouldn't rush.
Absolutely, and we need to individualize our therapies. I think that's the main message. Yeah.
100%.
Many thanks, my good friend. It was very informative. Very nice talking to you as always.
Grand
Take
plaisir.
care.
Thank you. Bye-bye.
Bye-bye.